just for a few moments take a look at some remarkable research findings discovered by the early osteopathic investigators, such as McConnell and Burns and Littlejohn. And just tell you how it was done. What sort of things were they doing to the cadavers, animal cadavers, not human. They induced artificially somatic dysfunction in anaesthetized animals. They were cruel. And the traumatism, the artificial induction of somatic dysfunction, was carried out to not to the point of tissue tearing. It's important. It wasn't gross trauma. It was anything that you and I would experience by strain or sprain. It wasn't carried to the point of laceration. It was rather a slight slippage or maladjustment of the articular surfaces. No more than that. Within weeks or months, they began to notice pronounced patho-histological changes in the soft tissues surrounding the subluxated articular structures, including muscles, ligaments, and fascia. What did they find? Do you remember that one of the last research projects I pointed on to you, the hemodynamics of patients after coronary surgery? Just keep that in mind, in the back of your mind, as you start to hear about what they found then. What they found was chiefly hemorrhagic points in muscles and in the meninges between the pia mater and the arachnoid, as well as congestive stasis of blood vessel segments. They noted clearly extravasation, we'll see pictures of it, in spinal cord grey cell segments, surrounding particularly the dorsal, less so the ventral root branches, and the sympathetic ganglion chain suffered very, very clearly. Those segments related to the lesion-induced traumatic. And finally, and very important, they noticed that the posterior nerve root, the afferent posterior nerve root, was more affected than the anterior afferent nerve root. It was the weaker, it seemed. And you can speculate as to why. You can give the answer straight away. Let's actually look at some of these slides. They are available in texts that I think we have, or is it down at Tunbridge Road?
Yeah,
Tunbridge Road.
Yeah.
You know, there's the college still at Tunbridge Road where Wellham worked, and there's a very good library of texts that can be bought, and this is in one of those texts.
It's in volume 2 of the technique book, I think.
Okay, yeah, that's right. Volume 2 of the technique book that I co-authored with John Werner. There's a section with these slides on it. In your own time, look at them slowly and carefully. We can't look at these slides now for the length of time it's needed to appreciate what's going on. But, as I said, they found visible pathological, histological changes in the arterioles, the capillaries, and the veins, and extensive hemorrhagic foci in and about the spinal cord nerve centers of the cord and the ganglia, including both the dorsal root ganglia. Remember, we talked about how important that may be in pain syndromes, and we're going to look at that later, as well as sympathetic ganglia. And in your own time, when you get these, you look at it on iTunes, or you get the list that will be made of this lecture, take a close look at some of these changes between normal small arteries and the degenerative changes seen in the post-traumatic arteries in areas in and around the spinal dorsal root ganglia, or in and around spinal sympathetic ganglia. It's fascinating. Really worth comparing and contrasting with the slides of normal and abnormal. Often seen within days, more often seen within weeks, and certainly within months of trauma being induced and nature not having corrected itself. So what were the biopsy findings apart from these histological changes? various degrees of abnormal tension were clearly noted in the capsula and articulating ligamentous structures. The capsule and the surrounding ligaments suffered very clearly. There were contractures in muscles in and around the area of trauma, and the hardening of fascia in and around the somatic area, which is palpable, and thickening of cartilage end plates. One of the earliest realizations that they had as a result of this increased afferent input to the spinal cord from these delicate articular structures like the capsules and the facets and the cartilage end plates was to affect certain spinal cord and ganglionic nerve centers, and they found that the most significant effects were vasomotor dysregulation. Great vasomotor centers in the medulla. Obviously, the effects must have reached medullary levels. Now, in terms of modern terminology, what you could say was, as a result of the trauma induced and the effects in the structures I previously mentioned, the articular capsules, the cartilage end plates, the facets, the ligamentous and muscular structures between the vertebrae, the attachments, there was an upregulated nociceptor activity at the site of the injured and inflamed tissue, aberrant mechanoreceptor and proprioceptor signaling from the dysfunctional articular movements resulted in contraction of muscle, hardening of fascia, etc. This barrage of afferent input was thought to chiefly produce a dysregulation of spinal cord vasomotor centers, affecting in turn vasomotor sympathetic nerves. It was a remarkably insightful conclusion, given that it was formulated over a century ago. In other words, the dysregulation of the vaso and visceromotor centers in the spinal cord would end up affecting the vasomotor system generally, and specifically in particular organs related segmentally to where the trauma was induced. It was chiefly a vasomotor dysregulation, first and foremost, before gross pathology began to be noted on dissection. I think we don't appreciate, when we're handling the spine day in and day out, just how remarkable is the blood supply, both arterial and venous, and the lymphatic drainage of the spinal column and the spinal cord. Just how delicate but profuse it happens to be. And how hopefully we are affecting some of the most vital mechanisms of the human body, if we can affect vasomotor activity in these very small but profusely supplied blood vessels. They noted that spinal cord nerve cells, these very tiny structures that we talk about so much, these spinal cord nerve cells, as well as the dorsal root ganglia and the sympathetic ganglia, were extremely sensitive to circulatory changes, including venous and lymphatic drainage. It's worth looking at these pictures. When you've got time, just mull over them, just look at them. Notice where there is perhaps a somewhat less well-supplied area of the spinal cord. Look where it's profuse. It's very interesting what areas and what segments are less well-supplied and what are more abundantly supplied. It may play a part in some of the disease or pain syndrome conditions that we meet. And terribly neglected, but if we're going to talk in terms of the effect of osteopathy and passive motion, there's no other side of the circulatory system more important than the venous side, the weak venous side of the circulation. And if we're talking about one of the main benefits of osteopathic treatment being enhanced clearance time of pro-inflammatory cytokines, for example, that clearance is basically lymphatic and venous. So anything we can do to improve the venous drainage of any part of the body, let alone the spinal column, may play a significant part in your being able to help the patient through an acute, if not a chronic, pain syndrome, let alone disease conditions. And they were well aware of that very early on because of these biopsies of the animal cadavers. That heading is as up-to-date as anything in modern physiology. You go into the internet, look up PubMed, see what work is being done in terms of neurotrophicity. Before Erwin Core died, a few years ago, he said if anything he did in his life was of any value or importance, it was to try. He failed, he said, he failed, but he tried to get the osteopathic profession interested in neurotrophic phenomena. He said he failed miserably. He could not convince the osteopathic profession that that was the most important aspect of our work. Yet Littlejohn was saying this time and again in his notes, that ultimately our work to affect disease conditions or the repair of orthopedic injuries is if we can affect the neurotrophic supply to the inflamed, infected, or injured tissues. What is neurotrophicity? That's a subject I'll leave for you basically to look up. But it's fascinating, and it's the thing being researched at the moment. That every cell in the body that is in close proximity to a nerve receives neuropeptides passing along the axon sheath. I'm giving away all the work you're doing at home. Anyway, that's in a summary. Neuropeptides passing down from the nerve cell, down the Schwann axon membrane, to the tissue, to the cells at the other end. Right. And that neuropeptide, if in any way diminished or affected negatively, will result in the pathological changes that you see in any disease condition or injured condition. Until and such time as the body is able to repair it, if the neurotrophic supply is restored or is adequate. Those neurotrophic factors are being studied more and more today, 100 odd years after it was talked about extensively by the man that brought osteopathy to Britain. Which means every organ, every cell in every part of your body must receive an adequate neurotrophic supply. And neurotrophic supply is as liable and vulnerable to neuro and microvascular compromise. I would have hoped to hear it all from you at the same time, never mind. It's just as vulnerable to that compromise as any other delicate structure that we've been talking about today. Pressure on the nerve, to put it crudely and bluntly, in a compartment syndrome will affect, to a greater or lesser degree, the neurotrophic supply of that nerve. In a few moments, I'll show it to you clinically. I have to deal with it almost every day in the clinic, in the hospital. The extreme effects of impaired neurotrophicity. Here it comes. Well, is it coming yet? Well, very soon. Getting on the edge of your seats. Trying to keep you awake after lunch. Before we go into that, just a quick word, because it's connected to this term called facilitation. It's another very common term bounded about in osteopathy. It's very correct in terms of neurophysiology. It's basically, it's basically any signal that reaches the spinal cord that alters or enhances neuronal activity. Any signal that reaches the spinal cord that alters or enhances neuronal activity is called facilitation. That's all it is. A chronic and high level of small fiber nociceptor sensitization, that is facilitation, leads to central sensitization, which we'll look at in a few moments. It leads to central sensitization, rather than just in the periphery where the nociceptors are being injured or affected, it can lead to central sensitization in the spinal cord nerve cells, and more seriously in the brain. In first order neurons, not just second order neurons in the spinal column, but it also leads to neurotrophic and vasomotor dysregulation. Before I put that picture on, just a word about the picture. It manifests inevitably a significant change in the outflow. On the grey rings over both somatic and autonomic routes from the spinal cord. Any facilitation going on there manifests on the grey ramus through, either passing through the spinal synthetic ganglion cells to peripheral receptors in the viscera, or affecting the ganglia itself. We're going to look a little later at more modern research, more up-to-date research, showing this degree of facilitation going on here in the dorsal root ganglion. How does it manifest itself clinically? Well, here's an example. And that is what I have to see. And we don't know what to do with it. That was another critical moment in my career when I thought I could step in and show my colleagues what we can do to them. I couldn't do it. I didn't help these patients. I can't. It's too far gone. There's something remarkable going on occasionally. I'll talk about it in a moment. But what do you manifest? What do you see? Unbelievable sensitivity. They can't even put a sheet on that. They can't have it touched. It's so sensitive. Pseudomotor changes. It's dry, shiny. Tissue texture changes if you can touch it. Trophic changes. The skin, the muscles, the tissues. All that can be attributed to alteration of motor, vasomotor, and neurotrophic spinal health. All due to central sensitization, either there or up in the brain. It's a chronic and high level of small fiber nociceptive sensitization. These are young, healthy individuals. It's an unbelievable condition called complex regional pain syndrome. It used to be called reflex synthetic dystrophy. And it's brought on often by no more than that. A knock, someone's shin, someone's hand. And what is just an ordinary bruise begins to develop into an increasingly dysregulated limb, to the point of necrosis, and where something like 10 to 15%, if I'm not mistaken, go on to amputation. It ruins ordinary, healthy people's lives, young people. If it can be caught within the first 3 to 4 months, it can usually be reversed by, thankfully, the prescription of ketamine drugs given intravenously, high dosages. It's the only thing that's known to be able to reverse the condition. Now, I thought, well, if the central sensitization is going on in here, and we just saw John Werner doing what he was doing to the baby to affect those spinal cord nerve cells, and that's what I'm trying to do all the time whenever I'm treating any acute disease or illness. I can come along and prove osteopathy in front of my colleagues like nobody else can. Didn't do a thing, didn't change a thing. And the reason was that it still wasn't strong enough to reach the higher cerebral centers, which we'll talk about in a moment. And that's still the great challenge with this condition. So central facilitation goes on in any one of hundreds of pain syndromes that become chronic, that don't resolve, that the body doesn't seem to be able to get over. So what we've got going on here in chronic pain syndromes is the characteristic of small fiber nociceptive cells, and small fiber nociceptive system, to sensitize to repetitive stimuli, so that even a minor irritation, be it physical or mental, may be sufficient to trigger or enhance a pain response. Minor dysfunction in the neck, bright lights, noise can set off the migraine attack. The body's ability to dampen these ordinary afferent inputs is no longer patent. So basically, can you read the text? It says nerves branching off the brainstem, here's the facial nerve, may become overexcited, leading to dilation of blood vessels. Trigeminal neuralgia is a worst case scenario. You don't want to see that in practice if you can help it, but it will come occasionally, especially in hospital practice. Here's a very good example of that central sensitization. And basically what we're talking about in summary is it involves greatly increased excitability of spinal and, most important, supraspinal circuits. We have to somehow reach, in many conditions, the supraspinal circuits. Not just with your hand, by the way. Hopefully, leaving you a little curious as to what we're going to look at a little later. As part of osteopathy, not with your hands. It really is like that. You can't imagine the spine in any other condition in central fasciculation, as if it was inflamed and on fire. I was very pleased to find this slide. So even the lightest touch, such as a sheet or movement, may provoke acute pain when, please remember this neuron, even when the wide dynamic range second order neurons or cranial neurons become sensitized. This is the most fashionable neuron being studied today in pain research, the wide dynamic range neurons, and we'll see why. This is a young, healthy girl. Her life is literally turned upside down. It's usually a single limb that's involved. It can be more than one limb. It's unusual, but it can happen. The patient's left leg is the one that's affected by complex regional pain syndrome. It's just an extreme example of facilitation and neurotrophic changes. Sorry.
Do any of these people respond in any way to hypnosis?
I was going to come to something.
Oh, sorry.
Unfortunately, no, but not enough research has been done to know whether some do and some don't. I just don't know what the numbers might be because it hasn't been done in sufficient numbers. I just want to stay a little longer on the neurotrophicity because it sounds like something very theoretical in the higher levels of physiology, but everything I'm trying to do with you today has direct clinical relevance. I'm trying to bring the most up-to-date physiology that may be part of our osteopathic work down to the clinical level. And it's these neurotrophic changes that are going on that you can actually see. You don't have to dissect the patient's tissues and look at them under a microscope. It's visible externally in the extreme advanced case. The brawny edema, the reddened and blackened ulcerated skin, the increased nail growth. How do you reckon, we have to do minor surgery in the department, including cutting a patient's nails in this complex regional pain syndrome, because they can't go near it themselves, they can't have anyone do it, so how do we cut their nails? We anaesthetize them. They have to be anaesthetized. Knocked out cold completely, otherwise you can't get near to cut their nails, and if you don't cut their nails, they start to cause injury to themselves, or to the other leg, or the other foot. Neurotrophic change. And obviously the pattern on heat distribution is quite different. It doesn't have to be a colder limb, it can be a hotter limb. certain stages of the condition. Okay. So it's all happening here and in the brain. Let's look at it in terms of the spinal cord level. Now here's something fascinating. The facilitation, this hyperexcitability, continues even when you section the dorsal root, even when you cut the dorsal root to eliminate the peripheral spinal input, the facilitation still carries on. Even when you cut the spinal root so that no input is coming in, the facilitation is still continuing in the spinal cord nerve cells. And even when you transect the spinal cord, the facilitation is still continuing. This suggests that facilitation actually arises in the spinal grey matter itself, not from descending brainstem influences. However, the descending cortical inhibitory pathways, the pathways coming down from the brain that inhibit pain, for example, the soldier that's been injured, that he's in the middle of a battle, and he still manages to run 2 or 3 kilometers with this major injury, and he only when he gets to the other end in safety does he realize he's been injured and the pain begins. He's run for 2 to 3 kilometers without pain because the brain inhibitory mechanism has managed to dampen the pain nociceptive signals by producing a whole range of chemicals such as endorphins. Opioids that are stronger than anything we can produce pharmacologically today. They're still stronger, the ones that we produce in our brains. So there's this tremendous mechanism from the brain to dampen pain when working normally. And it's what we try to appeal to in many conditions. Sometimes we succeed, sometimes we don't. And again, just a reminder, what is the effect of facilitation on the outflow over the somatic and the autonomic roots as they come out of the spine? What happens when there's this facilitation going on? It can affect skeletal muscle. We've talked about hypertonicity. Also, it's hypotonicity. It affects glands, including the immune glands and organs, and we'll talk about why just a little later. It affects blood vessels, and we've looked at that a little bit already in terms of vasomotor dysregulation. It affects the smooth muscle in organ walls and in the associated fascia. And again, we'll look at this a little later when we talk about immunity. It can affect the immunocytes themselves, white blood cells, for example, macrophages, lymphocytes. Fascinating. Absolutely fascinating. And we looked at some of the research that suggested this already. Let's make a little brain break now. It's coming to the front. Let's hope it works. The competition. Or allies. Now look at this little picture. This is basically what intervention is being done in the clinic where I work, pharmaceutically or by your GPs. Just a quick look. If there's a painful stimulus there, the nociceptors can be inhibited by anesthetics or opioids or NSAIDs that can affect it at its peripheral irritation. The pain is transmitted along the peripheral nerves, and along this nerve it can be inhibited once again by local anesthetics and alpha-2 agonists. That's where they will work. As it continues into the spinal cord and produces sensitization, which we just looked at, it can be inhibited once again by opioids because they also work at that level. NSAIDs also work at that level. NMDA antagonists work at that level, A2 agonists, and local anesthetics, and so on. And the conscious perception of the dog of that pain, regarding the pain, is inhibited by general anesthetics. You knock the dog out, you can't feel a thing. By opioids, and by A2 agonists, okay? All those are the results of pharmaceutical intervention. And these are a list of some of the more commonly used ones in any medical practice. And basically, it's working at these levels. Opioids on the brain level, affecting the descending modulation, also affecting the ascending input, local anesthetics at that level, dorsal root ganglion level, and local anesthetics, such as lidocaine, which is an analgesic that can be actually rubbed on the skin as a cream, would be working at that level, and anti-inflammatory drugs. There is a danger, which all my colleagues are aware of, in the use of these drugs, and that's the side effects. And they're constantly battling between the benefits of the drug as opposed to the side effects of the medication. Does one outweigh the other? That's the continuous juggling act they're dealing with, as any physician is dealing with, in daily medical practice. Does the benefit outweigh what's the opposite of benefit? The damage to the heart. This fact is one of the most mind-blowing bits of physiology that I read in the past decade and learned about in the past decade. That the immune system itself is innervated. In other words, distinctions that used to be held between the nervous and the immune systems have become less and less evident, with the finding that axons from the autonomic nervous system are present within the parenchyma of immune organs. Within the parenchyma. This little picture sums up a very important field of neurophysiology, and I'll talk about it in a moment. We're looking at the immune system and the relationship to the sympathetic nervous system. Lymphoid organs, such as the thymus in the child, bone marrow, spleen, lymph nodes, the submucosal plexus in the GI tract, and other lymphoid tissue, they're all innervated with noradrenergic sympathetic nerves. And even, look at this, even lymphocytes, macrophages, and granulocytes, even they possess neurotransmitter receptors. Amazing. I thought it was mind-blowing when I learned that. Even those white blood cells have neurotransmitter receptors. Every lymph vessel, virtually, not entirely, but almost every one, has a sympathetic innervation. And if you read some of the early osteopathic texts, such as the famous one by, so famous I've forgotten his name, Millard, he's talking about this all the time, and this is 1921, first edition. And we were laughed at, the osteopathic profession, talking in terms of innervation, immune system, lymphatic system. But these vessels are tiny, and I think we miss out a lot that we don't do more dissection, if any. I think if we really saw the delicacy of the structures that pass through myofascial connective tissue, then I think we would appreciate a little more readily just how wonderful it is, the body that does cope and does get away and does seem to be normal and healthy most of the time, despite greater or lesser degrees of compromise. We looked at this earlier. And basically our work in osteopathy, in palpation, is a search. To search for neuro and microvascular compromise, looking with the delicacy that we can and with the fineness of touch that we can, where there may be a compromise that can affect some of the most delicate tissues of the body, and yet so important, even in regard to the immune system. Let me move on to something that you've all learnt in your studies. You've all learnt the tracks that are involved in nociception. But I want to just point out to you something very important. Why it is that a slow, soft, non-invasive, non-painful treatment touch may dampen the nociceptive, afferent, painful experience that a patient is undergoing. What is it that's going on? You probably all know this from your studies. You know that pain and temperature, but pain travels along the spinothalamic columns, coming in from the free nerve endings at the site of trauma, for example, or inflammation, or infection, and crosses, decussates at the spinal cord level, travels up the other side of the spine to reach the relevant somatic sensory cortical centers. You know that light touch, gentle osteopathic touch perhaps, as well as vibration, and most important, proprioceptive pathways coming from the articular structures under your hand, be they facets, or the ligaments on either side of a vertebra, between the vertebrae, or the muscles, the erector spine, the small unisegmental muscles, so involved in proprioception. So light touch and proprioception is what we tend to use, vibration less so. But I would suggest oscillation, maybe a form of vibration, will pass into the spine, to the brain, in a slightly different mechanism along the dorsal column, where it only crosses over at the brain level. This is already the brain, this is already the medulla. Okay? So it doesn't cross over for most of the spine, which is represented by this tiny little height of line, and only at the brain does it cross over to then continue, as does the spinothalamic, to the sensory cortex. So both this dorsal column and the spinothalamic column of the previous slide, they both meet here before they go their separate ways. This column goes across at the spinal cord level, and the dorsal column carries on up and only crosses at this level. So the dorsal column on the next slide goes up to there and then crosses over to follow the same pathway. So they both converge here. Here's the pain coming in, and then you put your hands there in an osteopathic manner. You're introducing light touch, oscillation, and proprioceptive input along the same pathway up to that point. And something very special goes on here. We said just now that light touch and proprioceptors engaged in classical treatment, which is gentle. So, they converge. That's the correct physiological term for what's going on, where the two tracks momentarily come together in close proximity. Dorsal column tracks going up to the brain before they cross over. Spinothalamic tracks crossing over immediately on entering the spinal cord. But here is where it's all happening. Something very special is going on here. Convergence. Now it also converges at the dorsal root ganglia, which is something a little extra I'm going to talk about later, which is very important and very currently researched because of pain in regard to neurogenic inflammation. Sorry, the red, I forgot to turn it into yellow. At 3:30, quarter to 4 this morning. I didn't realize that I did all these slides with everything I wanted to highlight in red because it looks beautiful on the screen on the computer. I'd never used it before in PowerPoint. Came to the lecture yesterday just for a tryout, first lecture, and everything in red was invisible. So imagine what panic's there. Till 3:30, 4 o'clock this morning when I started to work on this lecture and convert it all to yellow, but I forgot this before. Okay. So convergence, it's going on here. And it's converging also with something else, which we haven't mentioned yet. There's convergence with visceral nerve fibers. Pain can be coming in from viscera, from your gut that's painful, or your heart that's painful. Okay. So there's also convergence going on with visceral nerve nociceptors. And this process, this mechanism of convergence of referred pain and referred analgesia is important to study when you want to understand referred pain. But this convergence also affects and influences somatico-visceral reflexes, as well as vaso and visceromotor, and trophic reflexes. Pain coming in through the nociceptors can converge with visceral efferents going back to the viscera, for better or for worse. For better, when it's your light osteopathic touch and your proprioceptive input dampening the nociceptive irritation of the visceral fibers coming in at the same level. You can make it much worse if you're heavy-handed, or you treat for too long, or you treat inappropriately.
Mervyn, where's the diagram from?
I'm just
Who
looking
to start?
at that. Where's that taken from? My favourite medical book of all, Guyton's Medical Physiology. The most wonderful physiology text, medical textbooks, in my opinion, ever written. I quoted something yesterday to most people at the lecture. It was banned by a number of medical schools in America, by the physiologists, by the professors of physiology. This was in the 1980s. Guyton, G-U-Y-T-O-N, Medical Physiology. M-E-D. Why was it banned? Students were passing their exams too readily, too easily. You read, you learn medical physiology by heart, if you can. It's a big textbook, you learn it by heart. You can answer almost any question set in medical physiology exams. Because he explains things so simply, so beautifully, so simply. The ban was lifted eventually, but it's the most wonderful book for any osteopath to refer to. So this is where it's all happening, because I'm now going to mention something I haven't. There's an inhibitory neuron that lies between the input from both the dorsal column and the spinothalamic column. But it is also an inhibitory neuron profoundly affected by impulses coming down from the brain. An inhibitory neuron that inhibits the pain nociceptive afferent input. And basically what I'm talking about is something you all know from the studies, which is Melzack and Wald's gate control theory. Pain comes in, we've talked about where it comes to. It could be C-pain fibers coming in. Okay? And you can have the brain descending inhibitory fibers. There's the gate. So the C fibers, the pain fibers, open the gate, allowing more and more pain to enter. Descending inhibitory systems push the gate closed, and these descending inhibitory systems have been found to be affected by things like electroacupuncture, by stimulating the brain's opioid mechanisms. Now, there are other ways of getting the brain to produce the opioids that dampen pain. We'll look at that in a moment. But you can also affect the pain mechanism by stimulating the A-beta fibers, which are only stimulated by light touch, or proprioceptors, or vibration. And they'll also help close the gate. A system such as TENS works on that system, with vibration, for example. Gentle massage. Every mother knows this instinctively. A child comes running and he's just damaged his knee. She just puts her hand lightly on the painful part and just gently strokes that part, affecting the A-beta fibers, the light, gentle touch, producing, apart from the psychological effect, a distinctly physical effect through this pathway, or your osteopathic hand. Well, we don't have to go with that, but basically it's looking at this whole system a little more closely in terms of the inhibitory neuron. And that's what's happening, basically. The descending cortical inhibitory fibers meet at an interneuron, there's the interneuron, to reduce the effect of nociception coming in through the A delta and C fiber, pain fibers. A less powerful dampening effect is through light touch coming in through the A beta fibers. And they meet at this spinothalamic transmission cell. This is where the convergence goes on. This is where it's all happening, either increasing the pain or decreasing the pain. This is our bread and butter. This is the mechanism we're trying to work with every day of our lives when we're treating pain syndromes. Did you all know this particular thing? Yeah, it's familiar. This is less familiar, I think, to some of you. This is what's being studied more and more today. Neurogenic inflammation. There's also a convergence of the kind we were just looking at going on here at the dorsal root ganglion. Dorsal root ganglion is being studied more and more in terms of trying to understand pain, especially chronic pain. You see, what they found was that 5 to 10% of the dorsal root ganglion cells in there are configured with bifurcating axons that receive a sensory input from both somatic and visceral tissues. 5 to 10% of the cells in that ganglion have a bifurcation, the axons bifurcate, so that one of the arms receives sensory input from both somatic and visceral tissues, such that it's unable to distinguish between the two. Pain coming in from your gut feels the same as pain coming in from a soma. This creates a situation where irritation in one tissue, for example, the muscle, strained muscle, irritated muscle, can back up along the path of its paired tissue, can back up its antidromic impulses now, causing it simultaneous irritation. At the same time as the muscle's irritated, it can produce simultaneous irritation in the viscera with which it is connected, giving you neurogenic signs of inflammation. It's not because there's an infection there. It's not because anything's physically traumatized the stomach. It's neurogenic. It's produced by the nerves that supply that organ being irritated by a related somatic structure. Now, that should be ringing many bells in your head in terms of the very first words I said in today's lecture about Still's discovery that there is often a somatic component to disease. That the muscles you feel with your fingers along the erector spinae, for example, or between the ribs and the intercostal muscles, that are hypertonic perhaps and sensitive, may be part of the picture that is also in the background of their gastric ulcer. And if you can reduce the neurogenic factor that may be involved in their condition, the body may be able to heal itself more effectively. Let's talk about how it happens. So the visceral primary afferent, this nerve coming from the muscle, will release pro-inflammatory substances into the undamaged viscera. And this is a mechanism for neurogenic inflammation. When do we break for tea?
Another 15 minutes.
Very good. However, sorry to disappoint you, are you going to miss something? Right, you have to look it up later. Yeah, listen. The gate control theory has not fared well. It's been around, it's been the basis of most of pain medicine for 40 years now. Unfortunately, things have gone wrong. Not wrong, things have changed. Most of the dorsal horn interneurons that were first identified by Melzack and Wall as inhibitory, as calming pain, are in fact excitatory. Those inhibitory neurons lying between the input from the dorsal and the spinal thalamic columns and from the brain are in fact excitatory. And in fact, recently it's been shown that pain reduction due to the gentle touch or vibration can result from activity within the cerebral cortex. That's the main site at which pain dampening is going on, with minimal contribution at the spinal level. That's the old one, where this neuron was considered to be inhibitory. Now we find that it's this pathway coming down, the descending control pathways from the brain are the most important mechanism of giving pain relief at this level. And at this level, of course, the ultimate level from the sensory cortex. The dampening mechanism is derived from the cerebrum itself, descending inhibitory pathways. That's where a lot of very important research is going on now, especially in the pharmacological, pharmaceutical industry, to produce drugs that do mainly affect the sensory cortex.
That the excitatory function is actually working positively by disrupting the input, and like TENS, I mean we use TENS to actually get a rhythm that actually facilitates in some way and then overcomes. So maybe the fact that it's excitatory is actually working with the body to actually disrupt all this input. And then you put in your calming effect at that level, and it helps to calm that down.
Look, the excitatory aspect, the central facilitation aspect, is a lifesaver. It saves your life time and again. It prevents you doing more harm to yourself. It prevents you leaving your hand in the fire. It makes sure that the damage done to your limb, having removed your hand from the fire, has time to repair while you're not continuously touching that part that still requires recovery from first or second degree burns. It's essential, central facilitation and pain excitation for recovery and avoidance of further damage and injury. But we're here to give relief where we can, to make life a little more comfortable for the patient. And if we can do so through hypnosis, for example, or other mechanisms that we're going to look at shortly, or a gentle touch, that's the best we can do as human beings.
I'm particularly interested in that, you talk about the vasa nivorum, the effect of vasa nivorum, and the effect on the actual localized ischemia to those particular gates.
Fascinating. This is what's being studied at the moment. Watch this space. Come back in 5 or 10 years and see what lecture I do then. In a wheelchair. No. You know, sometimes pictures sum up so much technical stuff. You can almost feel, these are beautiful pictures. You can almost feel the analgesic effect of those hands. They're not crude hands, they're very, very nice hands, working well. And they're stimulating powerful mechanoreceptor and proprioceptor responses. So every time, it used to be said, John Williams used to say this, he used to shout it, he didn't say it, he used to shout it at the students. You have no right to put your hands on a patient unless you have a deliberate intention. You don't fibble-fabble and put your hands on because you're just nothing else to do, unless you are either diagnosing or treating, you don't put your hands on the patient. And if you put your hands on the patient, do it with intent. And part of what I'm trying to do today is to make that intent an intelligent intent. Because I think it will make a difference if you approach an acute patient or a chronic patient, knowing that you have potentially a most powerful instrument underneath your fingers that you can explain to any medical person or scientist. The American Osteopathic Association brought out two statements in the late 1990s, which I want to read to you because I think it brings everything we've said today together. They said that the highly overlapping and integrated neural network in the spinal interneurons is acutely sensitive to afferent input from visceral, somatic, and descending brain areas. The highly overlapping and integrated neural network in the spinal interneurons is acutely sensitive to afferent input from visceral, somatic, and descending spinal brain areas. This acute sensitivity, as I've said, MW stands for, is particularly so with every degree rise in body temperature and in the presence of acute pain syndrome. It went on to say, any attempt, sorry I didn't correct this morning, it's 3:30 or 4 in the morning, I forgot to get it all lined up. Basically it said, any attempt to normalize the functioning of organs, muscles, fluid motion, and other body activities, any attempt to normalize these things, must attempt to encourage these complex and interacting networks with the nervous system to act in concert. Littlejohn and Werner continuously talked about integrating, correlating, coordinating. A treatment will only have a long-term effect if you can integrate and coordinate these interacting networks with the nervous system to act in concert. And when you see a well-performed treatment, I'm talking about classical treatment because I'm prejudiced, you can almost feel it, you can almost see it. In my third year of studies, I almost gave up osteopathy, one of the many occasions I almost gave up osteopathy. That was the first and earliest occasion, because what I was seeing and hearing from my tutors, I thought was rubbish. I thought was just so crude and so rubbish and so unscientific. Along came John Wernham, when I was in my third year, and started teaching on the faculty. And before he actually started his lectures, for some reason he gave a treatment. Someone was injured or ill. And as I watched him for the 15 to 18 minutes of the treatment, covering the whole body, standing, sitting, supine, prone, within 15 to 18 minutes, moving slowly, as you saw in that picture, yet every single significant part of the body was handled, at least for diagnosis, if not for treatment. And I watched the whole thing move and flow without stopping, as one continuum of activity. Gentle, slow, firm where necessary, but almost without break. I saw something with my eyes, and I felt something in my heart that was extremely beautiful, aesthetically beautiful. I couldn't understand what he was doing. I didn't know any of this stuff. But what I did see was something taking in the whole body into consideration, and doing so in a way that seemed to coordinate and integrate the bits and pieces of our body. Well, it has an effect on the neurological level, on the neuroendocrine level. And that's what the American Osteopathic Association statements are talking about. That there must be a way of doing what seems to be the case externally to also affect the internal physiological mechanisms of the body. And it does. But it's an art as well as a science, and the art is learning to do that takes some years, It takes a lot of practice. Just because it seemed so beautiful, I carried on, knowing that he was going to continue teaching. I stayed on in the college just because I wanted to hear him, and as I began to hear him talk and lecture using Little John's lecture notes very often, I thought I was going to go mad because I couldn't understand a word he was saying, and he would never explain anything. So we used to secretly put it all down on tape, because he didn't want us to take it away with us in any way, but he put it on tape, and I'd go away and have it typed out, and I'd read it again and again. I still couldn't understand anything. Just occasionally there was a sentence, like the ones I quoted to you right at the beginning of this lecture, this day's lecture, that just stood out like a beacon of light as something very interesting. And so I carried on, carried on, carried on. Often wanted to give up osteopathy for other reasons again. Just hung on because of these little beams of light that seemed to be coming through. Now, here is some of the most exciting work being done in medicine, and some of the most exciting work being done in osteopathy, believe it or not. Gene induction and pain. We've got another 2 minutes. How to do gene induction and gene expression in 2 minutes on one leg. Look, you all know that prolonged pain can lead to aberrant nociceptor neural activity. You all know that. Circuits have lower thresholds of activation. We've just been talking about that. And this facilitated response is triggered by a change in the cell's voltage. Neuropeptides are released into the extracellular space of the dorsal horn, for example, in the spinal cord, which signal the opening of channels allowing calcium influx into the cell. And this is where it happens. The calcium influx via these voltage-gated channels is actually involved in gene induction. That's how pain can produce gene induction. Now, a barrage of activity on the nociceptors can result in induction of RNA. This is a specific process of RNA for a substance called dynorphin. This can go on in numerous dorsal horn neurons. Now, why is this important? Something wrong there. Right. Now, dynorphin is a very important substance being studied because it's known to increase the sensitivity, that is, the facilitation of dorsal horn neurons. That's the mechanism by which things get more and more painful with less and less stimulus. The barrage of afferent input via nociceptors results in the induction of RNA for the substance called dynorphin in the dorsal horn neurons, and that in turn increases their sensitivity to any further afferent input. Okay. Now, where does osteopathy come in? Can osteopathy alter gene expression? Well, this is going to be mind-blowing for you that's still awake, all three. No, 4 of you. But this is remarkable. I quoted this research a little earlier. The role of osteopathic manipulative treatment in altering pain biomarkers. In other words, gene expression for inflammatory biomarkers, such as dynorphin, serotonin, can be reduced by osteopathic manipulative treatment. This is what this particular piece of research found. By activating the brain's endogenous opioid system. Your treatment and your proprioceptive and your light touch receptive input goes all the way up to the brain. There's no other place you can feel it except in the brain. And that in turn has an effect on dynorphin levels and serotonin levels, which can only be brought about by changing gene expression for those substances. So the question is, what is the effect of osteopathic treatment on the cellular components of connective tissue? And how may it affect gene expression? Cellular mediated responses. Now let's have a look. Some very simple research. We're going to look at this. We're going to look particularly at the fibroblasts and their relationship to connective tissue and to stretching of connective tissue, which is something that we inevitably are involved in when we're giving osteopathic treatment. We're going back to the mechanical instruction to understand this. I'll remind you what it is. It's the process of converting a mechanical stimulus into a cellular response. Okay? What has been found is that when connective tissue is stretched, fibroblasts, we looked at this a little earlier, respond within minutes by expanding, flattening, and actively reorganizing their cytoskeleton. The active cellular response has been shown to influence, among others, actin redistribution and actomyosin contractility. Mechanical stretching of fibroblasts have been shown to increase the transcapillary blood flow and alter interstitial osmotic pressure. But it also alters the balance of pro- and anti-inflammatory cytokines. Cytokine expression. And there's been some fascinating research in recent years showing how gene expression is altered in response to mechanical signals. All these are research findings regarding the process of mechanotransduction, its effect on the extracellular matrix of fascia. Externally applied mechanical force in loose connective tissue is likely to have substantial effect on fibroblast mechanical signal transduction processes. So why do we want osteopathic treatment to target connective tissue? We've noted that mechanical forces are important regulators of connective tissue homeostasis. And from in vivo experiments, it's been observed that an externally applied mechanical load can lead to rapid induction of distinct extracellular matrix components in fibroblasts, and that mechanical stress can influence the regulation of extracellular and matrix proteins. Fundamental changes in the fascia of the body. But most important, it also triggers an intracellular signaling pathway that activates genes, affecting gene expression and the modification of cell function. It can't get any deeper than that. It's a good point to break, because when we come back, we're going to look at this gentleman in America, in one of the osteopathic centers in Arizona, and the work he's doing in this field, which could put osteopathy on the map.
Okay, thank you, man. There's some tea downstairs in the basement. Also, there's some cake that we had yesterday when we